Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we are going to talk about that how this low molecular weight heparin or an injection Clexane helps us in tiding over that uteroplacental insufficiency, right? So as we know that the uterine arteries they they remodel according to the increasing growth of the fetus. So fetus, as we know, that has a journey between three trimesters, which is the first trimester, second trimester, and third trimester, and then the baby grows exponentially when the baby grows through this, or the journey goes through these three trimesters. So as the demand increasing, the supply has to increase, and eventually, because of some reason or the other, if the blood flow in the uterine arteries doesn't catches up or doesn't grows as synchronous with the growing demands of the fetus, and therefore we can have a uteroplacental insufficiency. Those uteroplacental insufficiency can be early and can be late. Now, early uteroplacental insufficiency can create some troubles to us because then the baby is premature and all these things they usually happen at 28 weeks. And so, meaning thereby that looking around for the fetal weight at something around 800, 900 grams, and therefore, how do we manage? It becomes very critical and very tricky, right? And therefore, the uteroplacental insufficiency can lead up into a high umbilical artery to absent end-diastolic flow in the umbilical artery to reversed end-diastolic flow in the umbilical artery, and therefore, we are left with no other option except to take the baby out, right? So, this low molecular weight heparin, so we identify the situation at something around 12 weeks, and then we follow them in 16 weeks. And if at 16 also we identify that the uterine arteries they have not the resistance have not gone down, and therefore she is in high risk to end up with an early uteroplacental insufficiency. So we start with low molecular weight heparin, and therefore we do, and then the ecosprin, right? Even though we identify that the ecosprin should have been started in less than 11 weeks, but all said and done, so let us talk about the real world experience, and let us talk about the let us be pragmatic and real world experience, right? So even though we have started this LMWH at 16 weeks, then also we identify that these titration of the doses is very very important, and then the doses which sufficed or which helped the to tame the resistance or to increase the flow in the uterine arteries at 16, 18, 20, 24 would not be sufficient at 24 weeks, 26 weeks. So, meaning thereby that the titration of the lumegribid heparin has to be done at a continuous process. And when the baby grows from 16, 18, 24, 26, 28 weeks, and so on and so forth, right? So we do have titration of the doses. So now we are dealing with a very good case in which all these things they were trying to do haywire and they were misbehaving. We increased the doses, and we identified that the clinical situation of the uterine arteries and the umbilical arteries has worked favorably well, and therefore we are able to salvage this pregnancy. So I'll explain all these things. So now look closely. This is the fetal weight. So we can identify that there was a dip at 28 weeks, and then the AC has also gone down at 28 weeks, right? And similarly, we could identify that the amniotic fluid index had also gone down, right? This was at 28 weeks. So this gave us the idea that probably we increased those of low molecular weight heparin that helped us in decreasing this uterine arteries. Both RI and PI bilateral has gone down less, and then this increased in the umbilical artery flows which is there in the RI and PI. We were able to tame it out across, and we were able to salvage this pregnancy, and therefore we are standing at 40. So keeping the the pregnancy under surveillance and monitoring on a continuous basis is very very important first. Secondly, we have also identified that from 24, 26, 28 weeks, or probably there would be need that probably we need to tighter or upscale the doses of low molecular weight heparin, which is very very important. So the doses which has worked at 24 weeks would not work at 28 weeks, right? At whatever is working at 28 weeks would is not going to work at 32, right? So meaning thereby that continuously this the fetus, the uteroplacental things across they need to be under surveillance, and the titration of the doses, and therefore the increment of the doses, it is very very important, and therefore it is very much required so as to keep the uterine arteries down, the flows in the uterine arteries down, and to increase and to keep the umbilical artery resistance down, so as to push up the amniotic fluid index and then the abdominal circumference and the weight. So this case has told us that probably we increased the doses at 28 weeks. The weight of the baby was something around the AC was lagging behind and all those stuff. So the weight was not appropriate for 28 weeks. It was less than that, and therefore we were dealing with something like 870, 890. Right? We increased doses. We had gone to 32 weeks, and therefore what we have identified is this, that there was a catch up from 870 something around to something around 1391 or 1400 grams. Now 1400 grams is a very good weight, and which if eventuality, if anything goes wrong, and therefore if we need to take the baby out, the prognosis to the fetus is very very good. It is very substantial, right? Vis-a-vis an 800 grams baby, and if we talk about 1400 grams baby. Even though the pregnancy is still going on, and we intend to take it up to 36 weeks, 37 weeks. Let us see by which day, and then we would identify that probably we will be able to reach to something around 1800 grams or 2 kgs. So that would be a take home baby, right? So the take home message is this, that it usually doesn't happens to all the ladies across in all the pregnancies, but 5-7% they we can identify an uteroplacental insufficiency, and then we can start with, and then we can do an evaluation, and then we can do a titration of this low molecular weight heparin or LMWH. This LMWH also needs some surveillance to the fetus at regular intervals so as to see when we would wish to shore up the or increment the doses of the LMWH so as to help or to tame this resistance of both the uterines as well as the umbilical artery down, and to help the baby grow, and so on and so forth, right? So so that is how it is. If so, earlier videos I have told you that if probably we miss on this these particular part, so that can lead up with an absent diastolic flow that can happen, and therefore the baby was 1400 grams in the previous slide, or this can lead to an reverse diastolic flow at 800 grams. So probably we are in a no man's land, and therefore a lot of difficulties we would face a lot of difficulties as far as the fetus is concerned, because then that would be an ICU or NICU admission. So that would be very difficult. Thank you very much for your patience.